So, good morning, good evening, and good night from everyone across the globe who's joining us for this edition of the EIOC Journal Club, where we'll be focusing on the emerging evidence in endocrine resistance and SERD-based strategies, looking at the clinical perspectives and future directions. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very warm, and I assure you, the very safe United Arab Emirates. And I'm joined today by some spectacular international as well as local faculty, and I'm going to allow them to introduce themselves. So, Virginia, it's such an honor to have you on board today. Please introduce yourself.
Thanks, Shaheenah, and thanks everybody for joining. So I'm Virginia Kaklamani. I'm a medical oncologist at UT Health in San Antonio, and I run our breast program here.
Thank you, Bassel.
Good evening, everybody. My name is Bassel Jallad. I'm a medical oncologist at Cleveland Clinic, Abu Dhabi.
Farooq.
Good evening, Farooq Latif, consultant medical oncologist, Dubai Hospital, Dubai.
Maha, I know you're having some technical issues, but please introduce yourself.
Maha, Sindi, medical oncologist from Kingdom of Bahrain Oncology Center. Thank you, Dr. Shaheenah, for your invitation. Glad to be here with you today.
Thank you. And Dr. Tarkan.
Yes, I'm Dr. Tarkan Yetisyigi. I'm medical oncologist in Bahrain Oncology Center.
So, Virginia, just to let you know, all these local and regional faculty, they're all my partners in crime. And today we are so looking forward to you talking or walking us through the clinical perspectives and future directions of actually incorporating SERD therapy, which is now the new kid on the block in patients with hormone receptor positive, HER2 negative breast cancer. And then post your talk, we're going to ask those tough questions. So everyone beware. So Virginia, take it away.
Perfect. Thank you. Thank you. So let me share my screen. Here you go. So, this is such an evolving field. These are my disclosures, and it's really, this presentation is going to be very different at the end of the year, the same way that this presentation would have been completely outdated and half of what it is last year this time. So really a very fast-growing field. So this is just a slide showing us the endocrine therapy approvals, and this is in the United States. But looking at just how slow the approval was in the 1990s and early 2000s, and now this explosion that's happened with CDK4/6 inhibitors, PI3 kinase inhibitors, antibody drug conjugates, and now ESR1 mutated targeted therapies with oral SERDs, and probably 2 other SERDs that will be approved by the end of the year in the US. I know one has already been approved at the UAE, so exciting to share some of that data from SERENA-6, but also to hear what you all are doing, because we're trying to figure out what to do. So when we talk about first-line therapy in ER-positive breast cancer, obviously we have to talk about CDK4/6 inhibitors. And even though in the clinical trials, the median progression-free survival of a CDK4/6 inhibitor is around 2 years, what we've seen with real-world data is that the majority of patients are going to be on a CDK4/6 inhibitor for at least 12 months. And this is really important in setting the stage as to what treatment to recommend in that second line once a patient's cancer has progressed on that first-line therapy. And this is what the ESMO guidelines are telling us, and it's very clear. Even though this looks like a complicated slide, it's actually pretty simple. So let's look at the left part of the slide. Patients, which are going to be the majority, that are on an aromatase inhibitor in the metastatic setting, but now have progression of disease at least 6 months after being on that aromatase inhibitor, and usually it's more than 6 months. Then those patients are still likely candidates for endocrine therapy. And now we have a lot of different endocrine therapy combinations that we can give. We can give everolimus and exemestane or fulvestrant. We can switch to a different CDK4/6 inhibitor. Or if the tumor has a PIK3CA mutation, we can pick an AKT or PI3 kinase inhibitor. If there's an ESR1 mutation in the tumor, then we want to be thinking elacestrant, imlunestrant. And then if there is a germline BRCA mutation, do not forget the PARP inhibitor that at some point we will be using for these patients. Now, the other kind of ER-positive breast cancer that is very endocrine resistant is on the right hand of the slide, where there's progression on first-line endocrine therapy in less than 6 months. Those patients really should be going to some cytotoxic therapy, whether we give an ADC or chemotherapy. That's something that we can discuss later. But the bottom line is those patients, if we do decide to give them endocrine therapy, it is going to be very, very short-lived. And the reason for that is endocrine resistance. But even though we talk about endocrine resistance as one word, this is a very, very complicated pathway or multiple pathways that are responsible for generating endocrine resistance. And you can see here this depiction where we have mutations in the ESR1, and that's one of the mechanisms of endocrine resistance. Then we also have changes in other receptor tyrosine kinase pathways, such as the HER2, such as the EGFR, such as the IGF, that again will make those tumors endocrine resistant. We have alterations in the PI3 kinase pathway. Those also account for endocrine resistance. And then there's those other mechanisms such as epithelial mesenchymal transition, epigenetic changes, the tumor microenvironment changing, and so forth. So this is just something to show you that just because we say a tumor is endocrine resistant doesn't mean that we're going to give one treatment and that's going to work, because it depends on what the mechanism of endocrine resistance is in that specific tumor. And that's why when we start thinking of this, combination therapies may actually make more sense, because they're going to target more than just one pathway of this endocrine resistance mechanism. And so we talked about ESR1 mutations. These are mutations that develop over time when a tumor is exposed to anti-estrogen therapy. These are mutations in the ligand binding domain of the estrogen receptor, and they make that receptor active. So the receptor does not need estrogen anymore to be activated. It's activated regardless. And if you're looking for them in the primary tumor, you're not going to find them. If you look for them in the metastatic tumor, you're more likely to find them. But the best place to look for them is in liquid biopsy. Now, these mutations, initially in that first-line metastatic therapy, we might find maybe 7% of these mutations. But in that second and third line, we'll find up to 40, even 50% rate of ESR1 mutations. So it's important that we know where to look. And obviously, it's important that we actually look. Now, the ASCO guidelines are recommending that we look for ESR1 mutations. The ESMO guidelines say the same thing, and the NCCN guidelines say the same thing. So at progression on endocrine therapy, if you think a patient is still eligible for endocrine therapy, please look for these ESR1 mutations, because it's very important. So we've given our CDK4/6 inhibitor in the first line. What do we do in the second line? And in the second line, I'll show you some combination data that I think is going to be very impactful in the years to come, because of how they're prolonging the progression-free survival. So the first data set I'll present is from the ELEVATE trial, and this is a trial that included several arms. It tested the use of elacestrant in combination with pretty much every other therapy we have. We looked at alpelisib, everolimus, the 3 CDK4/6 inhibitors, and we're also going to be looking at capivasertib. The 2 arms I'm going to focus on today are the elacestrant plus everolimus and the elacestrant plus abemaciclib. And that's because those arms were just presented at the San Antonio Breast Cancer Symposium, 6 months ago or so. So let's look at elacestrant plus everolimus. The patients on this cohort were pretty heavily pretreated. Also, the majority had visceral metastases, 72%. 20% had primary endocrine resistance, and they all had received a prior CDK4/6 inhibitor. Many of these patients had received several lines of therapy, and then 50% had previously received fulvestrant. The results were actually pretty impressive, 8.3-month median PFS with the combination. And what's really nice is the fact that in many of these trials, you're going to see an initial drop in the PFS, which shows that there's rapid progression in some patients. On this trial, we didn't see that. And that's important, especially when you look at other trials. It didn't seem to matter whether tumors had ESR1 mutations or not, PIK3CA mutations or not. All of these patients benefited from the combination of elacestrant and everolimus. So that's safe. Now, importantly, speaking of safety, everolimus was given here at 7.5 milligrams, not at 10 milligrams. And I know that from several Asian countries that I've visited, the addition of everolimus is associated with quite a bit of toxicity, such as stomatitis. So I think that 7.5 milligram dose might be a little bit better tolerated. And these are the adverse events, and you can see some nausea, diarrhea. Now, this is mostly a US study, so it may not represent exactly what's being seen in Asia as far as toxicities, but important to be using the stomatitis cocktail and so forth. Now, we have a phase 3 trial with a combination of an oral SERD and everolimus, and that's the EVERA trial. That was a trial that was presented last year where giredestrant plus everolimus was compared to standard of care endocrine therapy plus everolimus. This was a patient population that had metastatic ER-positive disease. They had received a CDK4/6 inhibitor, but no prior chemotherapy. And what they found was relatively similar results, 9.9-month median progression-free survival with giredestrant compared to standard of care of 5.5 months. That was statistically significant. And it also seemed to be more beneficial in the ESR1 mutated patient population compared to the wild type ESR1. So if you're going to use this combination, think of ESR1 mutated patient population, because that's where we're getting most of the data. Now, as far as safety, again, we have stomatitis. This was a global trial. Many of these patients were accrued in Asia, and hence the degree of stomatitis being much more than what we've seen in similar trials in the United States. Also, everolimus was given at 10 milligrams per day. Now, when we compare the two different trials, as far as the patient population that was on those trials, the ELEVATE trial had a little bit more heavily pretreated patients as far as when we compare the two. There was more primary endocrine resistance at 20%, no primary endocrine resistance in the EVERA trial, and so forth. So in general, a little bit more heavily pretreated patients compared to the EVERA trial. So this was a combination of everolimus plus an oral SERD. How about the combination of abemaciclib and an oral SERD? And again, from the ELEVATE trial, the combo of elacestrant and abemaciclib presented at San Antonio. Again, heavily pretreated patients, 92% had visceral metastases, 15% had primary endocrine resistance, 30% had received prior fulvestrant. Not all patients had received the prior CDK4/6 inhibitor. Around 50% had, which means another 50% were CDK naive. And you can see again a pretty nice median PFS of 14.3 months in this patient population. Again, we're not seeing a drop that we've seen in many of these trials. And we don't have the data here on ESR1 versus non. That data will be published relatively soon. But you're seeing a pretty nice benefit regardless of visceral disease or any other characteristics. And as far as adverse events, what we would expect with abemaciclib, we're just adding some diarrhea, but relatively well-tolerated regimen. And this is in contrast to the EMBER-3 trial, which is with imlunestrant, again, plus abemaciclib. And so this is the combination of imlunestrant and abemaciclib, which seemed to show efficacy both in the ESR1 mutated cohort and the ESR1 wild type cohort. Extremely important. Both of them generating a median progression-free survival of anywhere between 9 to 10 months. So very important. And some of these patients on the trial were pretreated with a CDK, some were not. Obviously, even the pretreated CDK patients received a pretty good benefit. And there was some question about overall survival on the combination arm, but there was an improvement with the imlunestrant and abemaciclib, not reaching statistical significance yet. I really don't expect it to, but that's okay. The trial was not powered to look at overall survival. And when we compare the two different trials, again, we're going to see the ELEVATE trial having a little bit more heavily pretreated patients, more primary endocrine resistance, but at the same time, we're still going to see some increase in the PFS compared to EMBER-3. Now, these are cross-trial comparisons. I don't like making them, but I do like seeing the patient population that was included in those trials, because that's extremely important when we actually start seeing patients in clinic. Now, there's also the Electra trial, which also combined elacestrant and abemaciclib, and you can see here the results of Electra and Elevate together as far as the combination of elacestrant and abemaciclib. And in patients that have more endocrine sensitive disease, so the ones that have been on a CDK4/6 inhibitor for at least 12 months, you're seeing now a median PFS of 16.6 months, which I think is pretty impressive. So just food for thought. But I think the bottom line from all of these trials is that we're likely going to be using more and more combination therapy in that second line setting. Now, a trial that's going on in Europe and will have results in the future are the Adela trial. And this is a combination of elacestrant plus everolimus, but the control arm is elacestrant and placebo. So there's no everolimus in the control arm. So this trial is answering really a different question compared to the Avera trial. Now, you all have camizestrant approved based on the SERENA-6 data. We've talked about SERENA-6 for quite some time, but I'll kind of give you my take. And these are the data that were presented both at ASCO and SABCS. So on SERENA-6, 3,300 patients were screened. 10% of them ended up going on the trial, which means a lot of patients are having a lot of ESR1 mutation testing before we find eligible patients. This is a trial that required patients to be on an AI and CDK4/6 inhibitor for at least 6 months, and then testing started happening for every 2 to 3 months with ctDNA to identify ESR1 mutations. If an ESR1 mutation was identified, then patients were randomized either to continuing the same therapy, the AI and CDK, or switching to camizestrant and CDK. And the primary endpoint was progression-free survival. The time to ESR1 detection was actually pretty long. The median time was 22 months. Now, around 50% of patients had a positive test in the first try. But those were not patients that only started at 6 months after the initiation of the CDK. They could have started 3 years later, as long as they had been on a CDK for at least 6 months. So this tells me that there's a lot of tests that are going to be done to find a positive ESR1 test. And we need to figure out whether our healthcare system can handle that, whether our clinics can handle that. So these are the results, the median PFS, and that was updated at SABCS, showing a statistically significant improvement from 9.2 months to 16.6 months. Very good data. But note that patients on the AI were able to stay on that therapy for 9 months, even though that ESR1 was creeping up, which tells me that we have 9 months before there's progression of disease. The other thing that's an issue with this trial is the fact that we're comparing 1 line of therapy to 2 lines of therapy. And so that makes that comparison, the median PFS, probably a little tricky to interpret. PFS2 was also significantly higher at 25.7 months compared to 19.4 months. We're going to have an update at ASCO in the next month or so on PFS2, which I think will be very interesting to see. And there was some quality of life data favoring the switch to camizestrant. So as a conclusion, I think oral SERDs are here to stay. We're going to be using them one way or another. We definitely should be using them in tumors that have ESR1 mutations, but I think we're going to be using more combinations because of that improvement in progression-free survival. The single agent oral SERD is giving us a median PFS of around 5, maybe 6 months. The combinations are giving us median PFSs of 8, 10, even 12 months. So I think that's where we're going to see the change. Now, of course, whenever we give a combination, we have to worry about toxicity. So we're going to have to discuss that with our patients. And I'm really not sure how to use the molecular progression data because I wish the trial had a better design. So based on the data that we have today, I am not compelled to look at real-time ESR1 mutation status in patients who do not have a clinical progression. But I'd love to hear the discussion with everybody else who's been using the SERD-6 data. So I'll finish with that. I appreciate everybody inviting me, and I'm looking forward to the discussion.
So thank you, Virginia. Awesome as always. And I think this is our opportunity. I actually have two cases that I have been asked to go through, but before actually going through those cases, I think this is a perfect opportunity to ask all our questions because you've presented some basically cutting edge data. So let me start off while Bassel and Tarkan and Farooq and Maha are thinking about their important clinical questions. For me, I'm going to be an opportunist and ask my questions. The first is, you very rightly pointed out the Elevate data, the Avera data, that's both telling us that combination may be the way to go in that second line setting post CDK4/6 inhibitor. Yet we do have approval for elacestrant, for example, as monotherapy, and imlunestrant as monotherapy by the FDA. And the NCCN guidelines, in all their wisdom, has actually already recommended imlunestrant with abemaciclib in that second line setting. So say suppose you have a patient in the clinic who's progressed on a CDK4/6 inhibitor first line, has had, say, a 30-month PFS, and upon progression of disease has a few liver mets, few lung mets, no, the tumor burden is not that high. What are you going to do if this patient has an ESR1 mutation? Is it going to be single agent elacestrant or imlunestrant? Or are you going to use the Elevate data and the AMBER-3 data and the Avera data to say, look, maybe combination is better? And this is assuming that you can do whatever you want at your clinic and not be regulated by anyone.
Yeah, I think that's a question really that we all have to answer, and I don't know that I have the right answer. I think for the patient that is what I'll call a well baby, just doing really well, minimum progression of disease, I like the single agent data. I think it provides a very good quality of life. I have these patients in clinic. I have a patient who's now 2 years on elacestrant. But this was a very carefully selected patient. This was a patient with a long duration on a CDK4/6 inhibitor, some mild progression, but then I switched to elacestrant. And that's what I'd love to do with these patients, elacestrant or imlunestrant. But for the patients that have a little bit more of a disease progression, maybe a little less time on that CDK4/6 inhibitor, I think that combination is going to be very important. The Avera data seems very compelling. The AMBER-3 data seems very compelling as well. But we know that we're going to increase toxicity in these patients, and we need to think about that.
So Virginia, correct me if I'm wrong, and I'll come to you, Dr. Tarkan. It's just an
Amma.
extension of my
Yeah.
first question. If a patient has a PFS of more than 18 months on a first-line CDK4/6 inhibitor, like this patient I just described, of 30 months and minimal disease burden, it's there, it's in the viscera, but minimal, you're comfortable giving single-agent oral SERD like elacestrant. The data does support it despite being a post-hoc exploratory analysis of EMERALD, because we've all seen it work in those sorts of patients. But what the problem that I have are in those patients with a shorter PFS. And I'm not talking now single agent oral SERD. I'm talking about combination oral SERD with a CDK4/6 inhibitor or everolimus. Neither did Avera, nor did Elevate, nor did AMBER-3 actually give us that sense of confidence that that combination is going to work in someone who, say, has a PFS of 6 months or who has a heavier burden of disease post that first line of CDK4/6, where perhaps we need to start thinking about DB06 rather than, combination endocrine therapy with an oral SERD in a patient with an ESR1 mutation. So what are your thoughts there? Do you have patients with a shorter PFS where you've given combination and it's worked? Because I'm just not seeing it in the data that's been presented so far.
I haven't given combinations because, as you mentioned, they've not been approved by the FDA yet, and it's gotten very hard for us. And what happens is, and this is the trick with all of these oral agents, right? They come to your clinic, they've had disease progression, and you're getting ctDNA testing. Then you tell them to come back in 2 weeks to get their results. So you've known that they've progressed for 3 or so weeks between the scan, your visit, and then the 2 weeks. And then 3 weeks later, you start prescribing the combination, which you don't even know if it's going to get approved or not. So they'll get the elacestrant and imlunestrant within, a couple weeks. That's 5 weeks. And then you're going to start fighting with the insurance about the abemaciclib. I don't think that these patients can afford to wait that long. These are your patients that if you were going to start them tomorrow, I think you should be giving them that combination therapy. But if you're going to start them in 6 weeks, 8 weeks, you should be thinking about it twice. So that's those are the practical considerations that we don't talk about too much. But when the patient comes to clinic, this is what we need to be thinking about.
And again, I'm sorry, Dr. Tarkan, but if you
Mhm.
had everything in your clinic and tomorrow you could give combination, are you confident giving combination to someone whose PFS is, say, 6 months or 8 months on a
As long as they don't
CDK4/6?
have very rapidly progressing disease, yes. So if you see that they have now 3 new liver mets, I wouldn't. I think that would be the patient that I'd want to start cytotoxic therapy. I move back to it. So I stabilize them with a cytotoxic therapy for 3 to 6 months, and then I go back to the endocrine therapy.
Okay. Dr. Tarkan, apologies. Please
So
go ahead.
my question actually was all the same, again, same topic. When the patient was on the first line CDK4 with abemaciclib, already on abemaciclib plus, let's say, aromatase inhibitor, and you have now this mutation, only you need to do like Serena to change the ESR
Sure.
part.
So you could, right? So you could. I typically use ribociclib. And to your very, very important point, the patients on these trials were mostly on palbociclib. And so now we're talking about a BEMA in somebody who's received palbo, and that's not fair because if we use a BEMA or if we use ribo, we just don't have the data. And we know, at least preclinically, that ribo and abema are better CDKs. So that's where I would think of everolimus. Again, I have the luxury to be able to give everolimus with very minimal toxicity. My understanding is that in Asia, Asian patients really
Very
don't do that
difficult.
well. Yeah.
Very difficult.
So that's something to kind of think about. And at the end of the day, it depends on how much time do you think you have to quote unquote experiment with endocrine therapy. If you think you have enough time, then try switching and see how the patient does. If you think you're kind of pressed for time, move on to the cytotoxic and potentially move back to endocrine therapy.
So let's stick to that first line data and let's look at SERENA-6 in the mix of all of this. And my question here is, SERENA-6 allowed you to monitor and look at that ESR1 mutation emergence. And at the time of emergence, if you didn't have radiological progression, you could then switch over to camizestrant plus the same CDK4/6 inhibitor. I'm going to ask a very practical question here. Do we need that CDK4/6 inhibitor in that patient? I'm not asking about, whether the trial should be implemented, but do we really need it? Because when I think about Emerald, and you've rightly pointed out, those long PFS patients in the first line setting, minimal burden of disease, they do well. You'll have a patient 2 years on elacestrant. In SERENA-6, you've got these patients almost 20 months before they actually had an ESR1 mutation with no radiological evidence of disease progression. Why not single agent oral SERD there?
I think you absolutely could. That's another one of the reasons why I'm not crazy about the SERENA-6 design. The whole point of combinations is that you're attacking 2 different pathways at once. But the minute you see that the ESR1 mutation is creeping up, that's the mechanism of resistance that you want to attack. So giving the oral SERD in that case would be very reasonable to do.
So, Dr. Bassel, what are your thoughts here about Virginia's not being excited about SERENA-6? Because SERENA-6 is approved in the UAE. Camizestrant's landed in the UAE as of today. will you do Serena 6 in the clinic tomorrow if you had the right
You're
patient?
right. I mean, I am intrigued. I feel I would be anxious not giving switch oral SERD for a patient who is in front of me acquiring ESR1 mutation. I prefer to change, but what you are mentioning is really the pivotal point here. Is that, I mean, do we need the combos or just switch to the targetable therapy, which is in this case the oral SERD, is what's going to make the difference. I mean, that's maybe, where my gonna be my hassle is. Maybe with time when we have such a trial to look into that. But otherwise, I don't think I will leave a patient who have acquired the ESR1 mutation without giving the oral SERD, even if it has, with the evidence I have to be in a combo. I mean, the patient, I assume, is tolerating well his CDK4/6 inhibitor. So I think switching from AI to an oral SERD probably will even improve their quality of life. Of course, first of all, is delayed progression, but also I feel oral SERD even going to be, in many different trials so far, is actually shows better tolerance than an AI. So I'm going to be definitely supportive of that.
Farooq, you have a question for Virginia.
I just want to ask this question. Thank you, Dr. Shaheenah. I think all of us have patients on single agent elacestrant doing quite well. I have a patient passing nearly 18, 19 months now. So with regards to this discussion of using single agent versus combination, I think over time we've also learned that there is some apprehension that quite a good number of patients actually progress within 3 months, 35 to 40%. Using single agent, I am a little bit reluctant now with my experience, although I have patients who are doing quite well. But with regards to the scenario we have discussed, 18 months plus PFS with a first-line CDK4 plus KI. So if we start patients on elacestrant and 6 months down the line, you see progression, what would you do? Would you add abema or would you add everolimus, or what would be your approach in that situation? Would you go and keep?
That's a good question.
That's a great question. Yeah, and I haven't really thought about that because I just thought if you're going to do combo, you do it up front. If you're not going to do combo, you don't. I think I don't tend to add things. I tend to change things. So if I were to give abema in that third line, I'd probably give it with another endocrine agent, whether that were fulvestrant or something else. But I can't justify that. That's just how I've usually done things, because I feel that if the tumor has seen a drug and progressed on it, why am I keeping it?
So there was a trial, and please correct me if I'm wrong, Virginia. There was a trial, I feel it was one of the most underrated trials, but for me, a very important one, that was published in CCR maybe a decade ago, called the TREND study. And if you remember, the TREND study actually took patients who had progressed on endocrine therapy, and upon progression on endocrine therapy, palbociclib was actually added to endocrine therapy, and patients actually achieved a very good PFS, similar to what you would get in the second line setting for CDK4/6 inhibitor. So I think the question that's evolving now, and that's I think what Farooq is trying to ask, like your patient has been on elacestrant for 2 years, and maybe at the third year she progresses, but the tumor burden is not that high. Would it be unreasonable to add everolimus or abemaciclib at that point and monitor closely and see is it overcoming the resistance that's acquired at that point? So would it be unreasonable? For me, I think it's not unreasonable, but I'm like Virginia. I think in the second or third line setting, I probably would experiment in the first line setting, but not in the second or third line setting, where things tend to go wrong very quickly in patients who've progressed even a little bit. And I find a lot of these patients, you need to rebiopsy. I recently went back to my data of my patients in the clinic. A lot of these patients have also lost their ER expression, and they turn triple negative on me. So I think it's important to work your patient up and really have that discussion and think about what your options are. Maha, do you have a question? Because I have a lot of questions for Virginia. I'm taking the opportunity to ask.
have
Let
a
me make
question.
one quick comment that we haven't talked about. Not all these SERDs are the same.
Yes.
So elacestrant is half SERM, half SERD, and imlunestrant is more of a pure SERD. So to your point, Farooq, I think I'd be more inclined to switch to imlunestrant and abemaciclib. then continue the elacestrant. Then we don't have any of that data. This data needs to be generated. How do tumors respond if you switch from one SERD to the other?
That's a very good point. That's a very good point. Yes, Farooq, you wanted to
I
ask
just want to
something.
ask a question, really. So it's a real case scenario. I have a patient 2 years plus on first line, slowly progressing. Molecular profiling with the foundation liquids was negative. So she developed liver mets, so we did a liver biopsy. And on progression, I changed her treatment to everolimus plus exemestane. In fact, she didn't want any injectable. So no actionable mutation, treatment changed, and I did a liver biopsy. Foundation tissue showed ESR1 mutation. So she's now about 5 to 6 weeks on everolimus plus exemestane. Now I know that exemestane is not going to work for her. Now I have the option of addition of elacestrant. Yeah. So my question is, in this particular patient, would you add elacestrant to everolimus, or the data you have presented is actually quite remarkable with abemaciclib plus elacestrant. So what would be your approach? Would you switch treatment, or would you continue everolimus and add elacestrant and see what happens and think about change at progression?
I personally would keep the everolimus and add elacestrant just because she's already on the everolimus. And so she's kind of figured out how to take it. If she's been on it for 5, 6 weeks, the stomatitis is likely not a major issue. Just make sure that that dose is 7.5, because we had weird infections with 10. We had some PCP, PJP pneumonia, things that we don't typically see in the US in patients with breast cancer. So that's why we had dropped the dose to 7.5.
So before I allow Maha to ask a question, if I may just ask, Elevate used abemaciclib in one arm and everolimus in another arm. Then you have Avera, which is using everolimus, and you have Amber 3 that's using abemaciclib. If you had a choice between the two, everolimus versus abemaciclib or a CDK4/6 inhibitor as combo in that second line setting with an oral SERD, which would you prefer?
I would ask the patient about toxicities. One's diarrhea, the other one's stomatitis.
And one's 10 times more expensive than the other as well.
Yes. I don't know how to pick otherwise. I really don't. I think the data is pretty compelling. Now, when you look at the data with abemaciclib, it looks to give us a longer PFS compared to the everolimus. But those are not fair comparisons because they're cross-trial comparisons and different patients going on each one. Plus, the everolimus cohort had 100% prior CDK, whereas the abema did not. So I would say, unless we have a trial that compares the two, I'd probably consider them equivalent, and the only difference would be toxicity.
Would
Maha.
may I add to this
Bassel.
answer?
Yes.
I mean, maybe if it was more appealing if a patient had palbociclib to start with, and we have knew over the years now that it is relatively likely weaker, but as a CDK4/6 arm, and as you mentioned, switching from, let's say, from a SERD to a more deeper SERD like imlunestrant could be same option. What we're saying here is we could switch from a palbo as a CDK to abema as a CDK. I feel a patient who had a history of using palbo as a CDK4/6 inhibitor, it's more appealing for me to use abemaciclib when it comes to the choice of adding either. And I think we have learned how to deal with the toxicity of the abemaciclib better. Everolimus still is an issue, as you said, in the Asian here. So I feel at least for our patient population, that could be more appealing for me, unless proven otherwise. And you also mentioned switching the targeted. I think with every progression, I would check for NGS. Maybe the patient lost a mutation, and that's part of the clonal evolution. There is some medicines I feel that we could do one after the other. I've seen more in the CDK4/6 inhibitor than doing one after another, especially if it's a different medicine or something after palbociclib works. And I noticed also, and I think more likely, like the HER2 amplification or overexpression, is that when there's a PIK3CA and it's a truncating mutation, more also likely that we will be using TKI after TKI. I feel that we are going to see that working. So sometimes I think continuing same class could work, but I think with time maybe we will streamline that better.
Okay, Maha?
Yeah, so I have two questions, and probably this is something that we discuss many times with you, Dr. Shaheenah. So in patients who have Q mutations, so they have both
Yes.
ESR1 and PIK3CA or KAKT or PTEN, would you be guided by burden of disease? Would you be guided by the frequency of the mutation? Or would you be guided by pure CDK, the duration on CDK4/6 inhibitors? So I would like to hear your thoughts regarding this. And my second question is that—
Let me answer the first one because I'm going to forget.
Okay.
So I don't look at the variant allele frequency. There was actually some really nice data generated from Emerald showing that it does not make any difference. The VAF really has to do with how much DNA is generated and how much ctDNA we have. So that I don't look at all. But I do look at the other two. So both burden of disease as well as duration of a prior CDK. So, if the duration of the prior CDK is, 24 months, but at the same time, the liver is full of tumor. I don't know that I'd be brave enough to give single agent endocrine therapy. I think I'd rather be giving chemotherapy, at least for the short.
Okay.
But Virginia, I'm sorry, I'm interrupting Maha, but I think this is a very important point that you brought up. So suppose you have a patient that has a moderate burden of disease, where the PFS is, say, let me make it difficult, and let me say it's about 9 to 10 months in that first line setting. She has a co-mutation in ESR1 and a PIK3CA, and you are able to give combination oral SERD plus a CDK4/6 everolimus versus doing something like capi plus fulvestrant. What would you give in that sort of a setting? I think that's what Maha is trying to ask. If you had both combination strategies, because I think now in the UAE, I'll be honest with you, not many of us are going to use single agent oral SERD irrespective. We're all getting on the bandwagon for combination because we are able to do it here. So what would you do in that setting, in a co-mutation setting?
So in a co-mutation setting, well, we have Elevate with capivasertib and elacestrant. And so that's what I would do. And that cohort is open for the PIK3CA mutated, regardless of an ESR1. So that's what I'd love to do. I'd love to be able to give an oral SERD plus an
But if you can't,
whatever inhibitor. Now, I don't know. I'm sorry?
But if you can't give that combo, because we don't have the
But if I
data
can't
for
give
that.
that combo, I would probably target the PI3 kinase pathway and give capi plus fulvestrant. I think that would probably be my strategy. I don't know that we had enough of those patients in Ember or in Elevate to be able to make those decisions.
Okay. All right. Yes, Dr. Tarkan.
I want to comment on that point. In the study of Kabi, who used CDK4 prior, because there are also patients who are not received CDK4, especially this group, combo mutation, the PFS was 5.5. Will this one change your mind?
I think these patients that have PIK3CA mutations in general, they're going to have a shorter median PFS. And all of the data has shown exactly that 5.5 month median PFS that you're referring to. 5.5 basically is 2 scans, right? So by the time you get to those 6 months, there's progression of disease. At least you're giving them 6 months of endocrine therapy. But you could switch to cytotoxic. I just don't know that I would move to a different endocrine therapy. I don't think we have that data yet for that.
So can I ask the question, Virginia, if you had to sequence therapy, you just said that you would start with capi plus, say, fulvestrant in that particular case scenario. And suppose the patient does well, upon progression of disease, would you be comfortable giving an oral SERD and a combination strategy oral SERD? Because we have absolutely no data telling us, that these agents will work one after the other. So
we don't.
What is
so
your
yes.
comfort level there, and have you experienced it?
I've done the opposite. So I've given elacestrant first, and at disease progression, I've given the capi. And the reason is that 5.5 months, right? So with Emerald trial was 5.5 months in that, endocrine sensitive patient population. In Capitella was 5.5 months. In In Solar One, it was 5.5 months, and I'd rather give single agent than combination. But in the era of us wanting to use combinations all the time, then I'd probably target the PI3 kinase pathway, and then I could potentially move to target the ESR1 again. I'm hoping at some point we get the combination data where we can do both at the same time.
Maha, you had a second question. I'm sorry I'm
Another
interrupting
question.
you.
Yeah, no, thank you. Thank you so much. So, I mean, we obviously have patients who were diagnosed before this sort of, having access to, at least in this part, having access to, liquid biopsy and getting, and sometimes, we have these patients who have been on, we're sequencing chemotherapy, and then after 4 or 5 lines, because we have the ability now to do the testing, you find an ESR1 mutation, or you find, that you wonder, although it doesn't fit the inclusion criteria of the clinical trial, would you use these patients, would use these drugs in patients who've had ADCs before, or who've had, multiple lines of chemotherapy beyond that was included in the clinical trial? Because we always discuss this. Sometimes we have some patients who've been on, for example, capecitabine for, years. And then later on now, because we have access to doing the testing, we're finding out all these mutations.
So I'll give you I'll give you 2 points. One is that Emerald did include patients with prior chemo, as long as it was just 1 line. So that's the data we have. None of the other trials have included anybody with chemo. And there were patients on Emerald, exactly as you said, have been on capecitabine, were doing fine, and then had progression of disease, were switched to elacestrant and had a nice response. And the second point I'm going to make is a patient that I saw years ago, who I had given endocrine therapy, had some fast progression, so I switched her to chemotherapy. I kept her on nab-paclitaxel for a long time, and she just really deteriorated clinically, had some progression, but mostly her quality of life deteriorated, and I was ready to talk to her about hospice. And that was pre-CDKs. And my PA actually said, why don't we just put her back on endocrine therapy? And I figured, well, nothing to lose. It was hospice versus endocrine therapy. Let's just do that. 4.5 years. I kept her in endocrine therapy with an exceptional quality of life. And this woman would have lost 5 years because I would have talked to her about hospice. So yes, I completely agree with you.
Yeah. Okay.
So before I ask Bassel what his question is, I want to ask you a question, Virginia, in terms of when you look at Elevate and you look at Amber, it appears to me that maybe we don't even need to test for ESR1 mutation and a PIK3CA mutation, because imlunestrant Abema and Abema and elacestrant or with everolimus seems to work irrespective of the biomarkers. So what are your thoughts there?
I'd love to not have to. When we were initially trying to get elacestrant approved, there was a movement from a lot of people, including our patient advocates, who would rather have an oral option. And we forget about this because we don't talk about it. But Emerald had 2 primary endpoints. One was PFS in ESR1 mutated. The other one was PFS in all patient population. And that was significantly positive as well. Obviously it was because it was driven by the ESR1 mutated patient population. And that's the argument that the FDA made and made us all want to do ESR1 testing. But these drugs are active regardless of ESR1 mutations. They're just more active than the standard of care in the ESR1 mutations, but they're active regardless. So I'd love to be able to use them in everybody.
Dr. Bassel, you had a question. You were muted.
It's more a comment. I think it's smart maybe from the team for SERENA-6 to run the test at time of mutation, finding the mutation, but wouldn't be more appropriate and more realistic is to randomize them at the time of actually starting the treatments. And like the Patina trial, isn't it, there is a selection bias there? And maybe I think is that the idea of how much patient we found with ESR1 mutation and then randomizing them at the time of mutation to see a doubling of the PFS could be not really the patients that we deal with from the first time of treatment, because we see so many patients, about 20, not 20, but about, let's say, 15 to 20% who actually fail from the first year of treatment. And yet we say, let's start testing from the first 6 months. So I feel that in the first 1 year to 18 months on a CDK4/6, we have to be careful, using this data and just depend on, and then they fail so fast, like within 6 months, okay, of an acquired mutation. Maybe with time we'll know that those patients still fail despite being on switching to an oral SERD. I just feel like there is a selection bias, okay, and the randomization should have happened from the time of starting treatment, and then based on how they did or did not acquire the mutation, to randomize them versus the standard of care to see how well they do. Don't you think?
Absolutely. So, Virginia, if I may ask the question, just an extension of his question, of Dr. Bassel's question. When you look at Amber 3 and you look at the monotherapy studies and you look at even Avera, in the monotherapy trials, you have almost a 60% drop off of that first part, the endocrine, I say the refractory endocrine therapy group of patients, where they're just not benefiting from anything. And then when you look at the combination therapy trials, you see it's at least maybe anywhere between a 15 to 30% drop off. So it's better, but it's still there. But when you look at Serena 6, there's practically no drop off because obviously there's no radiological progression of disease at the time of randomization. Should that not be enough for us as physicians in the community to actually adopt Serena 6? Because this way you're capturing everyone to be able to get something earlier on. And this is just, I'm playing devil's advocate and asking that question, because if we sequenced first line CDK4/6 to say Amber or Elevate or even or Emerald, you're still getting that drop off. You're still losing patients.
At some point, you're going to lose those patients. You're still going to get a drop off that's called progression of disease. And, I'll remind you of the clinical trials that were done back in the, early 2000s with circulating tumor cells and chemotherapy, where we were looking at the CTCs. And if the CTCs were going up, we were changing treatment, but without radiologic progression. And we found that there's no difference in overall survival between changing all these treatments versus waiting until radiologic progression and then changing treatments. And in the long run, the patients that had more CTC derived therapies had more toxicities because they were exposed to more chemotherapies quicker. Now, these are less toxic agents, and so this may not be the case. But, if they had replicated PATA-1 and the control group had received camizestrant at some point, and they still showed PFS2 difference, I would be buying it absolutely. But the majority of patients, the vast majority of patients on Serena 6 in the control arm never got an oral SERD. So we don't have that data. We can't compare this because patients were never exposed to a SERD. That's my major issue with the data.
Okay. And if I could ask one more question before you, Dr. Tarkan, because I can, very quickly, giredestrant. We now have data, both, well, okay, we haven't seen the data, we're going to see the data very soon in that first line setting, which we know is a negative study. But we also have data in the early stage setting where it's a positive study. Please explain to me how giredestrant is not superior to an AI in the first line setting, but is superior to an AI in the early stage setting. I just want someone to explain that to me.
I don't know that I can. I can tell you that I had predicted that the first line trials were going to be negative, but I had also predicted that lidERA was going to be negative. So I guess I'm 50-50. I think the major reason is that you're adding a CDK, and the CDK is just overwhelming everything else. And what endocrine therapy you're pairing the CDK with doesn't matter, because it's the CDK that's going to do the job.
Exactly.
And I wish Amber 3 included a fulvestrant plus abemaciclib arm, which it didn't, for other reasons. that would have been nice. Now, in the adjuvant setting, what I would suggest and assume is that we're just delaying the molecular progression with that oral SERD enough to get positive results.
I completely agree, because I think what we're seeing from the first line trials is exactly what we saw with Parsifal, where there was no difference between fulvestrant and AI when you added a CDK4/6. Lidera is positive. Only a small subgroup of patients received a CDK4/6. I think what it tells me, at least in that early stage setting, you're right, it's delaying molecular progression, but it's also telling us that maybe if you didn't want to use a CDK4/6 in that really low risk population that was included, you could potentially use an oral SERD. Dr. Tarkan, you have the last question. And then
No.
Farooq, so quickly, Dr. Tarkan.
Yeah. My question is about the mutations, ESR mutation subtypes, which would change any approach of you, or, there are sometimes more mutations, or
So,
are you following this kind of approach?
yeah,
Because we have the data also.
So I don't think we're smart enough yet to do that. I think you're right that not all mutations are the same. The data that we have is less than 4 mutations or 4 and more. And if we have 4 and more, there's the PFS is lower, which you would have expected. So I probably would not use an oral SERD if I have 4 or more ESR1 mutations. I've never seen that. I'm sure somebody has at some point, but it's really rare. But at some point, once we get a lot of data, and this is going to be a lot of real world data, we'll be able to differentiate between the ESR1 mutations. So far, the data doesn't show any differentiation.
Okay, Farooq, last question, 3 minutes. Then Virginia has to run off to her clinic.
Quick one, sir. So the patient with the 18 months of PFS on first line AI plus CDK4/6 inhibitor, ESR1 mutation positive, but high disease burden. So you decide to put that patient on DB06 TDXT. 6 months down the line, excellent response. No issue with the toxicity of treatment. When would you consider switching to endocrine-based therapy, on progression, or you're comfortable that the disease is under control and you can switch back to endocrine-based therapy?
I switch at those 6 months. I think that's an ideal time to switch. And then if there's progression, I'd go back to DB06 and give more TDXT. Because that's what I've done in the HER2 positive setting, and it's worked really well for me. I think we've all have. So that's typically what I do. I try to give 3 to 6 months of chemo and then go back to the endocrine therapy.
Shaheenah.
So,
Hey, Shaheenah.
yes, Dr. Bassel,
What do you
you have
think?
a burning question? We have 2 minutes.
What do you think? What do you think of Sonia team, like make a Sonia 2 trial, getting giredestrant as a first line alone or any oral SERD, and then CDK becomes a second line, and see if really like this or the switch, since we think the first line with the CDK oral SERD is the negative trials, but I bet you it would really look like the Sonia trial would work best when we do an oral SERD alone in the first line, spare the patients for so many months and years, maybe, on a CDK4/6 inhibitor side effects, and then maybe put it in the second line. I feel it's going to work well.
I completely agree with you. I think it would. I think the only issue that we would have is what you mentioned previously, that how positive are you that that patient will get to that second line? Because then we're
Probably be
selecting,
selective.
right? So we're selecting the patients that will make it to that second line. But I completely agree. I think that would be a positive trial in favor of the giredestrant arm.
I think in a place limited budget, that could work very well. But I agree with you. We need to be very.
That's assuming, Dr. Bassel, that giredestrant or any other oral SERD is going to be cheaper than a CDK4/6 plus an AI. And currently, I can tell you it's not. It's not.
Correct. That's another point. Cost.
So I was never even able to get to the cases because we were having so much fun asking Virginia all our questions, making us
Agreed.
better clinicians in the clinic on Monday in the community. Thank you, Virginia. I know you had to take time off your busy schedule. I don't know if you've had lunch. Please go have lunch before you attack your next couple of hours in the clinic. Thank you so much, Dr. Bassel, Dr. Tarkan, Maha, and Farooq for attending this edition of the EIOC Journal Club. Stay safe, and we're going to come back soon with another edition. Thank you.
Thank you. Thank you.
Good evening.
Bye.
Take care.
Bye.
Bye.
Bye-bye.